Hey, thanks for checking out this video. This video is kind of depressing. At least the title is depressing. Bad decisions kill patients. I'm thinking about decision making related to using medications well, and I'm going to tell you some of the things that my patients have told me. Perhaps some bad decision making on the part of patients, a little bad decision making on the part of doctors. I'm an internal medicine doc. I'm a clinical pharmacologist. I have a PhD in pharmacology, and I have 20 years of experience treating patients and discussing decision making with patients and other physicians, and that's what I'm leveraging for this video. This video is really intended for patients and also for doctors who are trying to make good decisions about treatment approaches. I'm going to talk about some of the hang-ups and biases that affect our decision making, and I'm going to talk about some strategies that we can use to try to overcome that. We'll look at a patient, and it could be any patient with any medical condition that requires some good decision making. I have a clinic where I see patients with atrial fibrillation, which is a heart condition. Patients who have atrial fibrillation are at risk for having blood clots form in the heart. These clots can float into the brain and can cause a stroke. We know that modern blood thinners can virtually eliminate the risk of stroke from atrial fibrillation. We also know that modern blood thinners thin the blood and therefore increase the risk for bleeding. Now, there's a certain amount of scientific information that informs choices, but there's also a certain amount of anecdotal information that patients bring when I have these conversations with them about what they would like to do to try to lower their stroke risk. And many doctors have a certain amount of anecdotal information that they have accumulated over their practice that also informs the decision making and sometimes can result in a bad decision, which could ultimately kill a patient. In our medical tradition, we assume that scientific information trumps anecdotal information. In my experience, my hypothesis, I guess, for this video is that anecdote almost always trumps science. And so you have to understand what your anecdotes are, whether you're the patient or the physician, and your awareness of that can then help you make better decisions. Some of the anecdotal information that patients have passed along to me when we're trying to make decisions are some of the following. The first thing that I hear a lot of patients say is, "Oh, doc, I'm the kind of patient that if there's something rare that's going to happen, a rare side effect, then it's going to happen to me." Well, no, it won't. This is completely magical thinking. And if you're a patient that thinks that, then you should go to the casino, because winning in a casino is a rare event. And if you think that's going to happen, well, then you should go to the casino. Unfortunately, there's an awful lot of magical decision making that results in, certainly in my country, my province makes a lot of money off of magical thinking and people going to casinos. I'm not sure where that went. The other thing I hear about from a lot of patients is that I'm a special case. Often I hear patients say this when it's something related to, for example, a common problem that is difficult to manage. So fatigue, for example. The bottom line is that patients are not special cases. Patients deserve special attention. But we see all cases, and more often than not, when a patient comes to me and says, "Doc, I'm a special case," I've seen many other patients just like them who also believe they're a special case. They need special attention. They are not special cases. Another thing that I hear a lot of patients say anecdotally is that, oh, well, my family responds differently to medications compared to most people. No, they don't. They don't respond differently. That belief, that anecdotal belief came out of nowhere, and it's not true. Another anecdote I hear from patients is, I'm especially sensitive to medications. I need you to start with a super low dose. Okay, if you're one of my patients, secret, you're not any more sensitive to the medications that I give out than any other patient in my practice. You deserve special attention, and we have to be careful about how we dose medications, but you are not especially sensitive to medications any more than anyone else is. It's worthwhile taking a minute to examine where your fundamental beliefs about medications come from. So, I hear patients saying all kinds of crazy things to me, like, Doc, I'm not a pill taker. I prefer natural remedies. I hear patients say that medications are unnatural. I prefer natural products. What's interesting to me is that most of the time it's the people who have never tried medication and have no experience on which to base an opinion who seem to have the strongest opinions. What right do you have to have an opinion about medications if you've never tried them? Well, your right to have an opinion is based on not just your own experience, but it's also based on the experience of your family and friends. And their anecdotes of what happened to them are fed back to you because you live in community with them. And then there are also cultural norms that influence the way we feel about medications. But it's important, if you find yourself in a situation where you have a strong feeling about something, take a step back and ask yourself, where did that come from? Fear is an extremely poor guide to good decisions. So if you are basically afraid, you'll probably make the wrong choice. Patients aren't the only ones who have anecdotal beliefs that influence their decision making. Doctors have lots of anecdotes that they allow to influence their behaviors. One of the problems as a doctor is that anecdotes of harm come to us every day. Every time you take a history and a patient says, well, Doc, I had a terrible bleeding episode. You get a quality improvement inquiry. A patient dies and you hear about it, and you're fed a steady stream of negative anecdotes of harm. You might get a call from the coroner about one of your patients. You might get a lawsuit filed that is about anecdotes of harm. The problem is that we are unduly exposed to the negative anecdotes and not to the positive anecdotes. I would say that for many doctors who primarily prescribe preventative treatments, we never hear the anecdotes of benefit. So I've never had that phone call on Monday morning where a patient calls up and says, doctor, I stayed up last night because I knew I was supposed to have that stroke, and I was watching TV because I thought I might lose my vision and might never get the chance to watch TV again, and I was waiting to sort of feel the drool dripping down my face and to feel the paralysis start to affect my arm, and then to slide off the couch onto the floor and have my stroke. And I woke up this morning sitting in the couch and realized that I never had that stroke. And I'm just so grateful to you for giving me the medication that prevented me from having that horrible, disabling stroke. I've never had that phone call. I'd love to have a phone call where a lawyer called me up and says, Doc, you know what? We're suing the government because you did such a great job with my patient or with my client who was your patient that I just think that you need to earn more money. Those positive anecdotes are never going to happen. I'm still waiting, but I don't think they're going to happen. Um, the bottom line is that doctors are influenced by negative anecdotes, and we are exposed to negative anecdotes far more than we are to the positive anecdotes, simply because we are not aware of events that do not occur. When we're preventing bad things from happening, you don't get to celebrate that. So, what's the impact of anecdotal thinking on the decision to take a blood thinner to prevent strokes in this patient with atrial fibrillation? Well, some patients just say, you know what, doc? I'd prefer to go without a blood thinner. Their risk of having a stroke is fivefold higher than it would have been. Some patients come to me and they say, doc, well, I believe that I'm more sensitive to medication than the average patient. And I notice that this drug is supposed to be prescribed twice a day. Because I know that my family's more sensitive, I've chosen to take it once a day. Again, there's lots of evidence from science showing that patients who take only half of their blood thinner expose themselves to a significant increase in the risk of stroke. Patients who have a bleeding event while taking a blood thinner often assume that the bleeding event is because they were taking a blood thinner. And one of the consequences of anecdotal thinking in that situation is that they don't seek proper medical attention, they never get their colon cancer diagnosed, and there's a missed opportunity. So ascribing events inappropriately causes lots of bad decision making. What happens with doctors? Well, doctors anecdotally decide not to prescribe to patients if the doctor is worried about the bleeding. And again, we know that in hospitalized patients, one of the biggest risk factors in a patient who requires a blood thinner for having a stroke is having that blood thinner stopped because of a bleeding event. So a bleeding event occurs, the doctor stops the blood thinner, the patient has the stroke. And so fear of the bleeding results in potentially an incorrect action that increases risk. The other consequence of anecdotal thinking that affects a lot of doctors is that doctors will choose not to prescribe drugs like blood thinners to patients who have magical thinking and believe that they have special risks or there's something special about them that's different from everyone else, because it would simply take too much time to convince them of the science. So, what is the science behind blood thinners in that gentleman that I presented to you who had atrial fibrillation and was contemplating this decision about taking a blood thinner? Well, it turns out that in this patient, if he chooses not to take a blood thinner, has about a 10% risk of having a stroke per year. That same patient, if he decides not to take a blood thinner, has about a 1% chance of having a bleeding event. If that patient decides to take an effective blood thinner, then the risk of having a stroke goes down to about 2% per year, and the risk for having a bleeding event goes up by 2% to around 3% total risk. So the net change in risk, if you decide to take a blood thinner in this situation, is that you have an 8% reduction in the risk of stroke at the cost of a 2% increase in the risk for bleeding. Now, most patients, when they grapple with that scientific information, choose to take a blood thinner. And I would say that they're making the right choice. But many times, anecdotes rolling around in their brain, their basic belief system does contribute to the decision to actually do the right thing in the first place, or the decision to stay on medication when they need to. The bottom line is that I think all of us need to think about what are the anecdotes that drive our decision making, and are the anecdotes that we live off harmful to good decision making And are we putting our patients at risk because we are sometimes making bad decisions? I hope you've enjoyed this video, and if you have any comments or thoughts about this, please leave a comment below. Subscribe to the channel if you want to see more of these videos. Thanks so much.
Dr. Dresser does not wish to take any responsibility for his opinions expressed in this video. Nothing in this video should be considered a therapeutic or diagnostic recommendation. If you are one of Dr. Dresser's patients and wish to be considered a good one, please adhere to everything in this video with religious fervor. If you are not one of Dr. Dresser's patients, please discuss these ideas with your healthcare provider.